Welcome, one and all, to Thursday evening master class, master stroke. Today, CCI is absolutely delighted to have a wonderful experts right across the country. The topic of discussion is acute presentations of ILD, recognizing the red flags and designing the treatment strategies. I am Dr. Vijay Kumar Chetty, webinar coordinator of CCI. With great pleasure, I would like to introduce today's moderator, Professor Chhabra sir. Professor Chhabra sir, honestly, sincerely, doesn't need any introduction to anyone in the pulmonary fraternity, right from Kashmir to Kanyakumari. But it's our honor to have sir today as a moderator. So welcome, sir. Sir is currently the director of pulmonology, sleep and critical care at Primus Super Specialty Hospital, New Delhi. And he is currently working as associated editor with various internationally reputed journals. And sir's area of interest, we know very well, is pulmonary function testing. If anyone wants to mention a name for spirometry and then advances in spirometry, the first name comes to each one mind is Professor Chhabra sir. Sir, namaste, and then absolutely CCI is absolutely delighted to have you, sir. And coming to today's schedule of events, sir will throw some light on acute presentations of ILD, extempore, then followed by my very good friend, Dr. Nilanjan Umesh. Nilanjan is hailing from Kolkata, senior consultant with Rajagiri Hospitals. He has specialized interest in critical care. He did IFCCM as well. And he has so many awards and accolades to mention. And thank you, Nilanjan, for having with us here. And the next talk will be by, and Nilanjan is going to set the flow by presenting a good case today. And the next talk will be by Dr. Nikhil Gupta, wonderful person. And I can say he is the one with extensive interest in thoracic radiology. In India, next to Bhavin Jankarya sir, there are only few names which we can hear who have a special interest in thoracic radiology. So one such is Dr. Nikhil Gupta, currently working as a senior consultant with SJS Hospital, Ludhiana. Welcome on board, Nikhil. And Dr. Arnab, good friend and wonderful human being, currently working as a consultant, Medica Super Specialty Hospital, Kolkata. And welcome, Dr. Arnab, and we will be looking forward for your valuable inputs and insights in today's webinar. And I must mention, if we have eminent thoracic pathologists across India, handful, one is Dr. Sharada Nagoti. And Hyderabad is extremely proudful. India is extremely proud to have Dr. Sharada with us to help and guide, handhold pulmonologists, because interventions anyone can do. Lung biopsy, reporting what it has, okay, based on which our treatment decides. Dr. Sharada is with us at Hyderabad for the past 2+ years and doing phenomenal work. And Dr. Sharada, thank you so much for attending or being as a panelist today. and I'm sure our audience delegates will be enlightened with your inputs. Currently, she is working with CPATH. She has her fellowship from Mayo Clinic and University of Washington. Welcome, Dr. Sharada.
Thank you so much.
And I must say, Girish, he looks like a teenager for me, but senior consultant. So, absolutely delighted to have very good dost. It's like fun means we have to sit with Girish. Academic means we have to sit with Chhabra sir. So like this. So thank you, Girish,
Thank you
for being with us today. And Girish works with Ramakrishna Care Hospital at Raipur, Chhattisgarh. Sir Chhabra sir. And with this, I'm handovering mic to you, sir.
Thank you, Dr. Vijay Kumar, for giving nice introduction about the great panel that we have today. This topic, when I was given this topic about a week back, I immediately accepted this because it was a very unique kind of topic. Normally, whenever we go to conferences, webinars, we have very typical topics like management and presentation. This one was acute presentation of ILD. So I had to think that how to organize the talk so that the important issues related to acute presentations are discussed. ILDs, as we know, these are more than 200 diseases which share certain clinical features, radiological features, pathological features, physiological features. That is why these are clubbed and discussed together. But there are subtle differences. Therefore, management of these diseases is different, and one has to, or at least strive to make a diagnosis so that correct treatment can be given. Now, when we talk of acute presentation, then the word acute has more to do with the time scale or the temporal pattern than severity. So acute in any condition means presentation over a very short period. So that is how, as opposed to chronic. We are all very much familiar with the chronic interstitial lung diseases, but acute presentations are something which are less often discussed, and the reason is that their management is much different from the typical chronic ILDs. It may be mild, severe, life-threatening, so that is a whole spectrum of severity that is there. So when we talk of acute presentations, then I could basically categorize into three compartments. One is the classical presentation known as acute exacerbation of IPF. That is a prototype, although it is now known that other idiopathic interstitial pneumonias can also have acute exacerbations. Then there are a set of ILDs which de novo have a very rapid presentation. That is, they evolve very, very rapidly, and they are very specific entities within this. So that is the second category. Third, patients with ILDs can have complications which suddenly increase their distress. So they would also come to the emergency with increased symptoms. So the common link between these three categories is that they will be presenting with increased symptoms and possibly respiratory failure. So this is the spectrum of presentations and diseases which we are going to discuss today with an exceptionally brilliant panel which has been introduced. And I hope that we'll be able to thrash out the issues, the controversies, so that at the end of the session, we are wiser and our audience that also goes back enlightened about the topic. So as per the format, we have got two presentations. One is a case which Dr. Umesh from Kochi is going to present, followed by a talk on radiological aspects by Dr. Nikhil Gupta. And then once the pattern has been set and the topic introduced clinically and radiologically, then we'll take up with questions from the esteemed panel. So I invite Dr. Umesh to present his case.
Thank you, Dr. Chhabra, sir, for the kind introduction. So, as I was informed about this topic by the esteemed CCI governing members, immediately a case which I had encountered last week, still in our ward, came to my mind, which is what I'm going to discuss today to set the stage for our further discussions. So, this is a case of a 62-year-old male who is a known case of chronic liver disease, L22, who came with complaints of fever since 3 days and breathlessness since 2 days. There was no history of chest pain, significant cough or crisis, and no history of other illnesses in the past. He was an alcoholic and he had stopped 2 years back. He is a non-smoker. He had no other significant family history. On an examination, he was tachypneic, tachycardic, restless, irritable, saturation of 80% at room air, which comes up to 96% on 4 liters of oxygen via nasal pumps. He had bilateral fine crepes on auscultation, and mild ascites was noted on examination. On initial investigations, he had a hemoglobin of 14.5, a total count of 5,400, a platelet of 58,000, probably due to his underlying liver disease, CRP of 66. The renal functions were normal. Bilirubin was slightly raised, again probably because of the chronic liver disease. SGOT SGPT was normal. The INR was 2.2. Ammonia was 78. He had a bit of hepatic encephalopathy, probably which explained his restlessness. Electrolytes were normal. His ECG was normal. His BNP was normal. And a screening echo done also showed a good LV function. There was no regional wall movement. So this is his X-ray. And as you can see, there are bilateral filtrates, scattered infiltrates in the X-ray. Presently, he was on 4 liters of nasal pumps. So now he was shifted to ICU for further management. Considering his acute history, we started him empirically on injection amoxicillin, clavulant, azithromycin, and oseltamivir. We did a nasal swab of influenza and COVID, which was negative. We got a little bit of sputum, which we sent for gram stain and culture, and which later on had come to be negative. Now, over the next 24 hours, he rapidly deteriorated. He had worsening breathlessness. He had fever spikes. His CRP increased. His procalcitonin which we did, was 0.5. And his oxygen requirement increased drastically. He had to be started on HFNC, which was increased to up to 70% FIO. And at many points, we thought that he would require intubation. And this is the X-ray we had done again. It showed certainly there has been an increase in the infiltrates bilaterally. So overall, what we were thinking of is an ARDS, probably a viral ARDS, considering the frequent cases of influenza which we are still getting, or an atypical pneumonia leading to an ARDS. So we went for an HRCT. It was a little risky with such a high FiO2 requirement, but we did manage to get an HRCT chest. And this is what we got. So as you can see, he had multifocal patchy areas of ground glossing with a little bit of patchy consolidating areas. And this is what the report was. We can also note a little bit of fraction bronchiectasis in the right lower lobe. So this is the what the radiologist reported: multifocal patchy and confluent areas in ground glossing opacity, septal thickening, interspersed consolidatory areas, bilateral lungs, and traction bronchiectasis changes in the right lower lobe and the posterior basal segment of the left lower lobe. The differential diagnosis given considering our history by the radiologist was still a viral ARDS. But considering a bit of traction bronchiectasis, we did think in the direction of an interstitial lung disease. We had no option but to broaden our antibiotic coverage to meropenem. We explained the high risk of intubation and did a bronchoscopy. We did not attempt a transbronchial lung biopsy because the patient was having a low platelet and a high INR, and there was a very high risk of bleeding. So we did send an extensive list of investigations from our lavage to rule out any sort of infection. We did a ball gram stain, which was negative, influenza PCR from the ball, which was again negative, due to which we later on stopped oseltamivir. We did a ball biofire, which has an extensive panel of viruses and bacteria, all of which were negative. The culture and sensitivity also later came sterile. We sent a galactomannan, which was negative. And later on, we had a preserved sample, which we also sent for PCP-PCR, which also came to be negative. So now the possibility of an ILD was getting a little more larger compared to an infective etiology. We had effectively rolled out most of our infections. We reviewed the history, but the patient did not give any history of joint pains. There was no history of exposure to pets or birds. There was no history of exposure to toxins or gases. We even consulted a rheumatologist and we sent an immunological panel, which was also negative. It was getting difficult to explain to the bystander why the patient was breathless. And so finally, we decided to pulse the patient with medial prednisolone, and we gave him 1 gram IV for 3 days. And then there was a significant improvement in the patient, both symptomatically as well as radiologically. As you can see, much of the ground glassing has cleared. So we made a diagnosis of probable acute interstitial pneumonia. Presently, he is still in the hospital, day 8 of hospitalization. His oxygen requirement has come down significantly. He is on nasal prongs, 2 liters per minute. We have tapered the steroids to methylprednisolone 40 mg 12th hourly. We are planning for an interval CT and a TBLB once stable after discussing with the relatives if there is no significant transfusion. So this case, what I wanted to illustrate was, as the topic goes, an acute presentation of an ILD, which was a very big mimicker of an ARDS, of a viral ARDS. So acute interstitial pneumonia, which I'm sure we might be discussing in our panel discussion, is a rapidly progressive and distinct form of interstitial pneumonia, which is clinically, radiologically, and pathologically very similar to ARDS. The mean age is around 50 years, no sex predominance, and no association with smoking. Lung biopsy shows histological features of acute or organizing phases of diffuse alveolar damage, which is also obtained in a case of ARDS. So there is no proven treatment, although corticosteroids might have some role which fortunately work for us. Many patients, they require mechanical ventilation. Many patients do not resolve on mechanical ventilation and they go on to require ECMO and eventually lung transplant. So with this, I'm ending my short presentation. I intended to show one of the acute presentations of ILD, the acute interstitial pneumonia, which is a common mimicker of ARDS, but does not have a proper etiology unlike ARDS. Thank you. And now I hand over Dr. Nikhil for the next presentation.
Good evening, everyone. Thank you, Professor Chhabra, for such a kind introduction, and thank you, Dr. Nilanjan, for such an interesting case. I would start by thanking Dr. Krishna, Dr. Vijay Kumar Chennam Chetty, and CCI family for having me here. Today, we will be discussing about radiological features of acute presentations of ILD. I am Dr. Nikhil Gupta. I am consultant radio diagnosis and imaging, SPS Hospitals, Ludhiana. Let's start with acute exacerbation of ILD, also encompasses acute exacerbation of IPF. It is acute deterioration of clinical features which develops within less than 1 month without precedent such as fluid overload, heart failure, according to newer criteria. On CT, there is bilateral ground glass opacification on background of more established pre-existent areas of pulmonary fibrosis or typical features of ILD. Here we can see a case of ILD in which we can see honeycombing, architectural distortion, and traction bronchiectasis, septal thickening, and again, the patient presented after 3 months with the episode of acute exacerbation, and there were GGOs present throughout. After 8 months, patient again presented with a second exacerbation, and there was a worsening of GGOs seen. And this patient had received a lung transplant later. Then coming to acute interstitial pneumonia, also known as Hammond-Ridge syndrome. It is the development of diffuse alveolar damage without identifiable cause, also known as idiopathic diffuse alveolar damage. It can occur from a collection of triggers. There may be inhalational exposure, aspiration event, viral infection, or hematological disorder that hasn't yet fully manifested. There are multiple patterns of injury like diffuse alveolar damage, acute pattern in which there is consolidation, GGO, crazy paving appearance. Then there is organizing and fibrotic type in which there is development of traction bronchiectasis and reticulation with anterior predominance. Then there is acute fibrinous and organizing pneumonia pattern in which there is consolidation and ground glass opacity in peripheral, peribronchial, and basal predominance. Then there is acute eosinophil pneumonia in which there is consolidation, GGOs, thickening of interlobular septa, bronchovascular bundles, small pulmonary effusions, and absent cardiomegaly. Here the distribution may be random or peripheral. On chest radiograph, there are bilateral patchy airspace opacities, which on initial stages are similar to ARDS. They are bilaterally symmetrical GGOs. Traction bronchiectasis occur in 80% of the cases, which correlates with duration. There is architectural distortion of the parenchyma, airspace consolidation with side predilection to dependent portions. This is a case of AIP. In early phase, there is basal predominance and anterior zones are spared. In late stages, anterior zones are also involved. This is a case of AIP triggered by sepsis. We can see diffuse GGOs, interstitial interlobular septal thickening, and traction bronchiectasis bilaterally, and there are also pleural effusions. Then, in this case, this was AIP triggered by surgery. Post-surgery, the patient presented with breathlessness, and we can see diffuse GGOs bilaterally. Later, the GGOs were resolved after 3 months, and HRCT shows residual fibrotic changes, which is which shows characteristic traction bronchiectasis and interstitial fibrosis. The differential diagnoses are ARDS, multifocal pneumonia, and drug-induced AIP. Coming to drug-induced AIP, these show multiple patterns like NSIP pattern, hypersensitivity pneumonia pattern, diffuse alveolar damage pattern, as we discussed a little while ago, organizing pneumonia pattern, or pattern similar to diffuse hemorrhage. It is difficult to diagnose on imaging. However, this is a case of daptomycin-induced acute ILD. And here in early phase, we can see peribronchovascular and central distribution of GTOs, which after a while, in like 2 weeks after this episode, showed extensive GTOs bilaterally. And after 10 weeks, it showed fibrotic changes in bilateral. This is another case of daptomycin-induced ILD. So here we can see consolidation and GTOs in organizing pneumonia part. Coming to leflunomide-induced acute ILD, its incidence is higher in Japan and Korea, likely due to genetic factors. The risk factors are underlying ILD, history of methotrexate use or methotrexate pneumonitis, using leflunomide, loading doses, smoking, and low BMI. On CT, there are diffuse GGOs, reticular opacities, consolidations, and honeycombing are seen in delayed presentations. Differential diagnosis include rapid progression of pre-existing interstitial fibrosis in rheumatoid disease and multifocal infective pneumonia. Here we can see a case of leflunomide-induced ILD in which there is peribronchovascular GGOs with septal thickening. Then in this patient, leflunomide was stopped and patient was put on steroids and cholestyramine, and patient improved in 3 weeks' time. So this is a post 3-week CT showing significant improvement. This, on the contrary, this is a case of rheumatoid arthritis, which was acute exacerbation of rheumatoid arthritis associated ILD. So we can see diffuse GGOs which are in random distribution. In earlier case, we saw diffuse GGO in peribronchovascular distribution. So this is the differentiating point. Coming to rapidly progressive ILDs or RP-ILD, these are seen in anti-MDA5 antibody positive amyopathic dermatomyositis associated ILD, or ILD associated with systemic sclerosis, ILD associated with acute interstitial pneumonia, and certain forms of ARDS. This is a case of scleroderma with rapidly progressive ILD. We can see esophageal dilatation in this case. With this patient had earlier had areas of these consolidations and GGOs in the periphery, and acutely progressed and acutely and rapidly progressed with the changes of reticulations and GGOs bilaterally. Coming to acute eosinophilic pneumonia, on CT, there is patchy bilateral ground glass opacity or airspace consolidation, interlobular septal thickening. Pleural effusion can be seen in 80% of cases. Bronchovascular bundle thickening can be seen in 2/3, and centrilobular nodules can also be seen. This is a case of 18-year-old female with acute eosinophilic pneumonia, with which resulted from new onset cigarette smoking. So on CT, septal thickening, diffuse septal thickening is seen with multiple foci of consolidations. This is a similar case, and we can see, in addition to above findings, small pleural effusions pilot. These are X-ray findings of acute eosinophilic pneumonia. Reticulations are seen in bilateral lungs, which after 3 days are partially resolved, and pleural effusions are seen bilaterally. Last but not the least, we will cover acute hypersensitivity pneumonitis. Here, the chest radiographs are generally normal. Bilateral areas of increased opacities, which may be heterogeneous, homogeneous, and can simulate pulmonary. Numerous opacities are seen in bilateral lungs with sparing of apices and bases. Fine reticulations are seen with variable zonal distribution. On CT, there are homogeneous GGOs which may be bilaterally symmetrical or otherwise, centrilobular nodules less than 5 mm, and mosaic attenuation, which persists on expiratory scan. And there is lower zonal predilection. Here we can see multiple airspace opacities in bilateral lungs, more on the left side. So this is an atypical case. And we can see GGOs and septal thickening. The differential diagnosis include infection, edema, and NSAP pattern pneumonia. Thank you for your patient listening. Now I would like to hand over this session to Professor Chhabra for panel discussion. Thank you very much.
For the topic, it was a very interesting case of an ILD presenting acutely, and then a wide collection of cases representing the typical radiological features. And one would have realized that it's not easy to make a diagnosis because the clinical picture is so similar. So that is the purpose of our panel discussion, to thrash out the difficult areas in this field. So we'll start with the definitions first. So Dr. Arnab, the prototype of acutely presenting ILD, acute exacerbation of ILD. So how do we define clinically that this is likely to be an acute exacerbation of ILD? Dr. Arnab?
Yes, sir. So first of all, thank you, CCI, for inviting me in this webinar. And regarding the question, so in acute exacerbation, what in cases of ILD, what we can explain, like, acute deterioration in symptoms within a span of last 1 month in a known diagnosis of ILD, but sometimes definitely ILD can present with a de novo exacerbation where the cause is not known. But still, typically, a new onset of bilateral GGOs or consolidation in a background of ILD picture, and you are ruling out the other causes like heart failure.
I think we lost connection. So as Dr. Arnab has said, that
acute exacerbation of ILD,
an acutely presenting increased symptoms, the time period of 1 month is important, less than 1 month of deterioration. Because I said in the beginning, the term acute means the time scale. So by definition, it's worsening within 1 month, and it's a diagnosis of exclusion that other causes of acute exacerbation have to be excluded. So Dr. Agrawal, usually we associate acute exacerbation of ILD most often with IPF. So which is the commonest idiopathic interstitial pneumonia which is associated with acute exacerbation, and what other idiopathic interstitial pneumonias can have acute exacerbations?
Good evening, everyone. At the offset, thank you, CCI. Sir, as you have asked, all of the exhibition of ILD has been basically exemplified on the basis of exhibition of IPF. So IPF exhibiting is the most common ILD, ranging from around 15 to 20%. But there are many ILDs which can exhibit. Among those, the most common ILDs are one which presents with UIP pattern either on the CT scan or on the histopathological diagnosis. So the UIP pattern presenting ILDs are like fibrotic NSIP, chronic HP, asbestosis, occupational lung disease like silicosis. It could be fibrotic sarcoid. So these are a second group of ILD which has an UIP pattern. Now there is a third group of ILD which can also present as an acute exhibition, and those are like with associated with inflammatory myopathies. So they can also present with an acute exhibition, but yes, the most common being the IPF exhibition.
Yeah, see, well, we don't include the de novo ILDs with the rapid onset. So these are
Yeah.
basically chronic ILDs. So that is the first requirement, that they have to be chronic ILDs, and then there are periods of acute flare-ups. So that is
Yeah.
by definition an acute exacerbation of ILD. And besides, like Dr. Agrawal said, not only IPF, but other fibrotic ILDs can also have acute exacerbations. Dr. Arnab, coming back to you, now these acute exacerbations, we know that most of the causes of ILDs, which can be associated with acute exacerbation, themselves have a poor prognosis. But once they have acute exacerbation, then how is the prognosis immediate and within the next few months for these patients?
Yes, sir. Yes, sir. Yeah, basically, yes, the most common one is the IPF. So basically, the short-term mortality following this exacerbation is quite high. Even in hospital, mortalities are seen up to 50% of cases, I think. And even 1 year mortality following a exacerbation is almost increases to 80% in some areas. So definitely with the IPF exacerbation, it's poor. Definitely some ILDs like acute interstitial pneumonia, other things, they have or more very worse outcome. And some ILDs, even if the ILD exacerbation is due to some complication like infection or heart failure, then there is a good chance of outcome. And if there is some non-fibrotic ILDs, predominantly ground glass opacities, the non-fibrotic, they have a better outcome. But definitely IPF, exacerbation, AIP, these are had a very good worse outcome.
Yeah, but it is important. See, we don't include acute interstitial pneumonia in acute exacerbations of chronic ILD. That is a different set of ILDs.
Yes.
So these are exacerbations in chronic ILDs, which get flared up, and not only immediately, but within next 6 months also, these patients have a very, very high mortality. Response to treatment is poor because we don't have randomized controlled trials on the best management in these patients. So, Dr. Nilanjan, now we have defined acute exacerbation of chronic ILD as a diagnosis of exclusion, which means that certain other conditions have to be excluded before we say that it is acute exacerbation. Because if those conditions are there, then it is not acute exacerbation. Right? So just enumerate, we'll be discussing the diagnostic criteria for those causes later on. Just enumerate some of the conditions which we have to exclude before we say that it is acute exacerbation of ILD.
Absolutely, sir. So, acute exacerbation is just a diagnosis of exclusion. So, one of the most common mimickers of an acute exacerbation is heart failure. So, even the history is similar. There will be a sudden onset of difficulty. On auscultation, we'll get fine crips.
Just enumerate because we'll be discussing these features later on also.
Yeah, so heart failure is one of the condition. ARDS is another common mimic. Then any infection, new onset infection, and patients with pulmonary embolism, they also present with sudden onset breathlessness similar to an acute exacerbation. And even pneumothorax for taking an imaging or diagnosing, they also present similar to an acute exacerbation. So all these have to be ruled out before we can term it as an acute exacerbation of an ILD.
Right. And as rightly said, these conditions make a difference in management because these conditions are treatable conditions, whereas an acute exacerbation of an ILD is not really a very well responsive condition. So we must identify conditions like embolism, pneumothorax, infection, heart failure to identify a factor which can be treated because that makes all the difference in the treatment. So Dr. Nikhil, You have made a very good presentation, and you have already covered this question, but let's have a bit more about this. On a CT scan,
Right.
if a previous CT scan is available for a patient who has had IPF, then how do we say that this is acute exacerbation of IPF in this patient? Comparing the two CTs, previous and the current one.
In the original CT, there are features of ILD. We can typical features like honeycombing and interstitial thickening, and there is architectural distortion. But in acute exacerbation of ILD, we can see developing ground glass opacities. So if there are ground glass opacities, we should consider alternate diagnosis as we have been taught. So alternate is like other patterns or some other causes. And once we rule all these out, then whatever is left is acute exacerbation of ILD.
So if a previous CT is available in these patients, that is a very valuable input, because over a background of previous ILD, if new opacities are appearing, new GGOs especially, and no other feature of any alternative diagnosis is available on that, then it is highly suggestive of an acute exacerbation. So now we have talked about possible causes which are treatable, which must be identified, which must be excluded before we diagnose acute exacerbation. So in a patient who has a known ILD and presents with acute respiratory failure, there are certain complications and conditions to be differentiated. So we'll take these possible treatable causes one by one. So Dr. Girish Agrawal, pulmonary embolism in a pre-existing patient with chronic ILD, how would we suspect and work on?
So basically, as Dr. Nikhil pointed out, that if there is acute exacerbation of ILD, the disease per se, there is a new ground glass opacity or consolidation. In pulmonary embolism, the CT might remain the same, but still the patient will be hypoxic, which is not justified looking at the radiology of the picture. So, and we know that ILD is a prothrombotic state. So the investigation protocol in any case of suspected pulmonary embolism remains the same, with CTPA, CT pulmonary angio remains the gold standard. If in case CT pulmonary angio cannot be done because of the very criticality of the patient or non-availability of the CT angio, or he cannot be shifted, VQ scan might be done even if the patient has got CKD. So VQ scan, CT pulmonary angio is the first choice. Then we can have a VQ scan. Even in some cases, though it is because in ILD patient, we see there is a quite a secondary pulmonary artery hypertension, and there may be some sort of RA-RV dilatation with right ventricular dysfunction, but a new onset RV dysfunction, if it was not present earlier. So this might be also a clue.
Right. So that is the difficulty in diagnosing embolism, that these patients may have chronic effects on the right side of the heart. So pulmonary hypertension and RV dilatation is already there. So a vital diagnostic sign of pulmonary embolism is therefore lost. So in these patients, and many of these patients who are chronically hypoxemic, bedridden, they are at a very high risk of developing DVT. So we need to have a high index of suspicion of pulmonary embolism in these patients. And if these patients can be taken up for CT scan, then certainly a CT pulmonary angiography is a very, very useful diagnostic tool in these patients. So Dr. Nikhil, heart failure is another condition that we have to rule out in patients presenting with acute exacerbation. So we have the history available there, like orthopnea, then the patient may be having edema. Echo may show a left ventricular dysfunction that supports our diagnosis of heart failure. We can do BNP, cardiac markers. Now on plain X-ray and CT scan, what would be the signs which suggest that this is heart failure, which might be causing acute increase in the symptoms?
Yes, sir. On X-ray, sir, there are certain signs like septal thickening and ground glass opacities more in the central distribution or peribronchovascular distribution. that we call as a bat wing sign. And there may be airspace opacifications and air bronchograms may be there. Pleural effusion may be there, bilateral, generally bilateral. This is what we look on X-ray. And we can remember it by a mnemonic ABCDE. That is alveolar opacification, bat wing, cardiomegaly, septal lines, and effusions.
CT
And
scan.
on CT, we see ground glass opacification more in the peribronchovascular locations with peribronchovascular bundle thickening and interlobular septal thickening. These are the main signs.
And there may be evidence of bilateral pleural effusion, which is symmetrical. So that supports. Because in acute exacerbation of IPF, we don't expect a pleural effusion.
Right.
So this is a very important diagnostic feature which would aid in pointing towards heart failure. Dr. Nilanjan, infection, that is always on top of our mind. In your case also, the patient was treated, and that is the universal protocol that all patients who come with acute exacerbation, infection is at the top of the mind, and we always start antibiotics while searching for the. So in your protocol, you have already told about all the investigation that were done. So how will we confirm infection, and which are the important infections to rule out in patients suspected of having acute exacerbation of IPF?
Yeah, so infection, we can get a little bit of clue from the history, right from the history, like some of the family members are also having fever and the patient himself is having fever. Symptomatically, some of the patients may be hypertensive, unusual in a case of plain exacerbation of ILD. So that hypertension can also indicate infection. And radiologically, if we go, some of them will be having consolidation patches in their X-ray or their CT, which is again not seen in an acute exacerbation of an ILD. And of course, as I had mentioned in my presentation, if we are able to do a bronchoscopy for the patients, that is the best way probably to rule out infections. We can get a bronchoalveolar lavage and send it for various infections. The common infections, again, as I had mentioned, many of these patients might be immunosuppressed. So PCP pneumonia would be one of the atypical. Other atypical infections also we need to rule out, like mycoplasma, H. influenza, even viral infections which may pass off as mild in non-immunosuppressed patients can be extremely severe in this group of ILD patients because they will be on some sort of suppressants like steroids or methotrexate or cyclophosphamide.
And that is a dilemma we always face, that while we are searching for the bug, we don't get it very often. And but still the patients have to be treated with a broad cover of antibiotics. But we must, like you said, do all the microbiological methods, molecular methods to try and establish the diagnosis, because that makes all the difference. If we are able to identify the infectious agent, then the outcome for the patient is much different from an acute exacerbation without any obvious cause. So this is a reversible and treatable condition.
Yes.
Dr. Arnab, some of these patients who present with acute respiratory failure may have a pneumothorax. That can also present acutely, and that is quite common, a secondary pneumothorax in a patient who has a long-standing chronic IPF. So how do we go about working, and then briefly, how would we manage these patients?
Definitely, sir. Definitely, pneumothorax is a common complication, and clinically, definitely absent breath sound on one side, along with the hyperresonant and the shifting of mediastinum. That clinically we can identify pneumothorax very well. But definitely, with a chest X-ray, we can show the pneumothorax. Even in ICUs, we have bedside USGs which can show this lung point, absent B line, barcode signs. There are many signs which you can see in the USG thorax also. And definitely when there is a confusion, we always go for a CT chest, which can definitely confirm the diagnosis. And because this is a secondary pneumothorax, definitely it should be like if the patient is in significant symptoms, definitely we should treat them with a ICD insertion, and according to we have to follow the.
Right. So management of pneumothorax is a very separate topic in these patients, and we can go into
Yes.
entire range, including the management of BPF and all. But these are possible complications. So, because if the air is evacuated, we can expect a rapid improvement in patient's respiratory failure. So that is very important to quickly diagnose and start the appropriate management. Then all these patients who have got capillaritis as part of their vasculitis, they can have a diffuse alveolar hemorrhage and present with diffuse shadows respiratory failure. So, Dr. Agrawal, how would we establish our diagnosis of diffuse alveolar hemorrhage in patients who are suspected of having an acute exacerbation of IPF?
Sir, there are two clinical method is one, then bronchoscopically also we can do it. So clinically, with a diffuse alveolar hemorrhage, besides the clinical deterioration of the patient, there will be fall in the hemoglobin. They might be associated with other microvascular hemorrhage showing in the form of microscopic hematuria or frank hematuria. While we do a lavage, there is a subsequent aliquots turns pure. The first few aliquots will be very reddish in color, and then the subsequent aliquots turn pure. So, which again indicates that there is probably an pulmonary alveolar hemorrhage. Recently, we have a patient who was operated for the hernia, and then post-operative, after 6 to 8 hours, he developed this bilateral diffuse alveolar hemorrhage with a persistent hemoglobin requirement, daily transfusion of PCV about 1. He was losing around 1 gram of blood in his lungs. And still he is admitted with us and is being managed with the antibiotics as usual course besides steroid. So yes, diffuse alveolar hemorrhage may have, as already Dr. Nikhil pointed out, that the presentation of acute exacerbation may have many pictures, particularly with the drug-induced or alveolar hemorrhage or NSIP or both. So this two method can help us.
So and that makes all the difference in management. And if we can establish DAH, then the line of management is much different from acute exacerbation of IPF. So it's diagnosed. Then coming to another important cause which has to be ruled out is drug-induced lung injury. And many of these patients, especially those with fibrotic connective tissue disease, they are already on immunosuppressants. And some of these drugs have been reported to cause acute exacerbation. Then Dr. Nikhil has beautifully shown some of the cases where a drug-induced flare-up was there, and that mimics an acute exacerbation of ILD. Now, diagnosing a drug-induced lung injury is very difficult because it's, again, related to history. So we need to be aware about the possible reactions to these drugs, like leflunomide is there, methotrexate is there, and some of the anti-cancer drugs, nitrofurantoin. So these are possible agents. Even statins have been blamed to cause an acute onset ILDs. So good history of drug intake is important, and and it's very difficult for us to remember. There's a very important, useful site called pneumotox.com. So I would recommend to our pulmonologists and residents to start looking up that site for entire range of adverse effects which may be associated, because many of these drugs can have these rare manifestations. Then ARDS is another condition which has to be ruled out. So Dr. Nilanjan, in a patient whom we suspect he has an acute exacerbation of a chronic ILD, how would we rule out ARDS?
It's going to be extremely difficult to rule out ARDS in a patient who is already having a pre-existing ILD. We can compare the radiographic appearances, like what the patient, if the patient has a baseline CT, and if there are extremely new changes, new ground glassing, diffuse bilateral ground glassing, And if we strictly go by the Berlin definition of ARDH, these patients are going to be extremely hypoxic. Their PF ratios are going to be extremely low, like less than 300. But even an acute exacerbation of an ILD is also going to cause extreme hypoxia. So probably one of the differences, if the patient is on ventilation, what I have observed is that ARDS patients do respond to PEEP better than a patient who is just having an exacerbation of an ILD. So, but otherwise, I think clinically and radiologically, it's going to be
The
extremely.
criteria for ALDS will be fulfilled by acute exacerbation of IPF also. That is.
Yeah, it's going to be extremely difficult to distinguish.
So, Dr. Sharada, my apologies to you for getting you in late because we had to set the tone clinically and radiologically. But in ILDs, we cannot do without a pathologist, right? That we have to sit together with the rheumatologist, radiologist, and of course the pathologist if the tissue is available. Now, acute condition is something which we are even afraid to put in a scope, what to say of a biopsy. So there can be limitations that we have less interaction with the pathologist in acute exacerbation. But in literature, there is a lot of material available from cases where it was possible to obtain tissue or from post-mortem studies. So I would like you to tell us that in a patient who has got a typical IPF, and then he develops an acute exacerbation of IPF. Now we have discussed the CT features. So pathologically, how a classical IPF and an IPF in acute exacerbation, how that will differ. Dr. Sharada, your mic is on the mute. Yes.
Yes, sir. Thank you, sir. And thank you, CCI, for giving me this opportunity. So, coming to the answer to this question, so the biopsy also shows features similar to the radiology features. Like they show a background of the underlying chronic interstitial lung disease. Along with that, there are superimposed features of acute lung injury. Like in the case of IPF, the histological correlate of IPF, idiopathic pulmonary fibrosis, is UIP, that is usual interstitial pneumonia. So what we see in a biopsy is in the background of UIP features like architectural distortion, dense fibrosis, showing spatial and temporal heterogeneity, fibroblastic foci, and honeycomb changes. So all these changes as they are there, these are the changes of UIP pattern of fibrosis. On top of that, there are features of acute lung injury. In cases of acute exacerbation of IPF, the features of acute lung injury are presence of alveolar edema, fibrin, hyaline membranes, and type 2 pneumocyte hyperplasia. So when these two are there, then I will diagnose this as an acute exacerbation of UIP. I cannot say it is IPF because IPF is a clinical diagnosis. So then I will correlate with the clinical and then the radiology, and then I can give in the comments saying that most probably the underlying UIP pattern of fibrosis is because of IPF.
Thank you. So whenever tissue is there, definitely pathologist's opinion is very useful. And some of these conditions, like I said in the beginning, not all these patients are extremely, in critical conditions. Some of them have that's the beginning of the respiratory failure. So in early stages, we should strive and try to get a tissue so that a histological diagnosis, because that is like we have seen in the radiological picture, that so much overlap is there that it may not be possible to pinpoint the diagnosis. So your opinion is definitely very, very valuable.
Thank you.
So now we have been discussing certain ILDs which have by their very nature, their natural histories of acute presentations, not like IPF or fibrotic ILDs. So these present very acutely. So Dr. Arnab, can you tell me about the distinctive features and prognosis outcomes in acute interstitial pneumonitis? Case was discussed, but in your experience, how do you approach and how you find the results in these patients? Dr. Arnab, your mic is on the mute, I think.
Nice case presentation already done on this AIP, but definitely AIP is the most, most dreaded complication, most dreaded kind of its acute exacerbation, and it's usually presents with a very short history, like a 2 weeks to 1 month history of progressively worsening cough, fever, and breathing problem, and rapidly progress into hypoxia. And maximum of this patient usually land up in mechanical ventilation. And if you go by the CT picture, it's almost kind of similar to ARDS. Okay, so you will not get any so much special things on CT scan, but definitely once it goes into the fibrotic phase, then you can get some amount of this traction bronchiectasis and kind of things, from where you can suspect the possibilities there of a AIP, and definitely you have to exclude the other infective causes and the other possible causes by the appropriate methods. And the treatment is usually supportive. There is no such kind of basic treatment like you have to go for a mechanical ventilation and the supportive care. Definitely, in some cases, high dose pulse dose therapy, methylprednisolone therapy can help. Definitely, regarding the prognosis part, this is a very high mortality in these cases. More than 50-60% mortality is there. And even after recovery, there is a high mortality chances in next 1.5 to 3 months.
Uniformly poorer outcomes. And historically, it's very important to mention that this was the first time when an ILD was recognized. This used to be called an Hammond-Rich syndrome.
Hammond-Rich syndrome, yes.
That is the history of ILDs. So similarly, and another acute presentation, ILD, is organizing pneumonia, sometimes called cryptogenic organizing pneumonia. An older term was BOOP. So Dr. Agrawal, presentation, how do we diagnose and prognosis in cryptogenic organizing pneumonia?
Sir, cryptogenic organizing pneumonia is usually diagnosed radiologically, but confirmation can only be done with the help of transbronchial lung biopsy. So there are many radiological features which may point towards the cryptogenic organizing pneumonia. It has got varied presentation. It may present with a patchy peripheral alveolar opacities. It may present with a lobe nodule. It may present with a solid mass-like consolidation, or it may have a reverse halo sign. So in the background of without any immunosuppression or not any immunosuppressive therapy, if the patient is presenting with a chronic symptoms and has those reverse halo sign or a patchy peripheral alveolar opacity, we tend to biopsy that lesion, and there will be fibrin exudate lining the endobronchial linings. So usually this patient responds very well to the 0.75 to 1 milligram of methylprednisolone per kg body weight, tapered off over the 4 to 6 weeks. So this patient is a one category of patient where the ILD exacerbation usually respond very good.
Yeah, that is a very important point to note, because we need to suspect this in these patients, and if other causes are ruled out, then definitely steroids are called for, and the response is very, very good. Then another condition which presents acutely, and Dr. Nikhil showed us radiological features, acute eosinophilic pneumonia, which again is a condition which develops acutely in a previously healthy person. Usually there is a peripheral eosinophilia, but sometimes the peripheral eosinophilia may not be there. Radiologically, it is recognized, and on BAL, we can get eosinophilia more than 25%, which is virtually diagnostic of acute eosinophilic pneumonia. So, Dr. Nikhil, you have told us about the radiological features. So, quickly, just to enumerate.
Yes, sir. On CT, sir, there are bilateral patchy ground glass opacities, interlobular septal thickening. Pleural effusion is common, around 80% shows pleural effusion, and bronchovascular distribution of the patchy opacities with bronchovascular thickening and centrilobular nodules.
And like organizing pneumonia, this is another condition which responds very well to steroids, and patient can be virtually cured, maybe a little bit of residual damage, but this is again a condition which has a very, very good response to steroids. So again, to say that not all acute presentations of ILDs are having a uniformly dismal prognosis. So this has a good outcome. Dr. Umesh, what about drug-induced ILD management?
So, drug-induced ILDs are a little confusing. Like some of the drugs that we use to treat the ILDs itself can cause ILD. For example, for rheumatoid arthritis presenting having ILD features, we do use methotrexate, which itself can cause ILD. So it's a little difficult to diagnose. So recently I had a similar case like that. So of course, removing the offending drug is one of the main things that we can do, and we have to find an alternative to the immunosuppressant like which we are using. Radiologically, again, there are varied patterns. It can be diffuse ground glassing. It can be UIP pattern, subpleural, this thing, and traction bronchiectasis. The mainstay is, of course, the offending drug, removing the offending drug.
Right. So
Some of the
awareness,
common ones like methotrexate and amedron, and yeah, those are.
so awareness is very, very important about drug-induced lung injury. Now, you have mentioned methotrexate. Now, what I have read is a little different. That methotrexate, although it was said that it causes interstitial lung disease, bulk of evidence, what I have read is that it causes pneumonitis rather than interstitial lung disease. So it can cause a diffuse pneumonitis, but as a cause of ILD, jury is out. That there are differing opinions on this. Right? So then Dr. Nikhil, you have told us about the radiological features of acute hypersensitive pneumonitis. I may add that again, this is another condition which is very much steroid responsive, acutely developing, and very often have a history of exposure. Sometimes the HP that we do that can come a positive, and so this is again a diagnosis which has to be suspected. And the radiological features can be very helpful in making a diagnosis. And these patients, when treated with steroids, have a very good outcome. So, Dr. Nikhil, you have already told, so I think we'll skip the radiological features of acute hypersensitive pneumonitis and then move on to the other acutely presenting ILD, and that is a rapidly progressive ILD, most commonly seen with idiopathic myopathies, inflammatory myopathies, especially dermatomyositis conditions which are positive for anti-MDA5. So, Dr. Girish Agrawal, how do we suspect this diagnosis, and then how do we confirm and manage? Dr. Agrawal. IIM-induced rapid progressive ILDs. Good. Dr. Agrawal, your mic is on the mute.
Sorry. So first of all, we have to confirm that the patient is a case of dermatomyositis or polymyositis. So that may be a preceding history which presents already the patient comes with. So he has a dermatomyositis or polymyositis, and any ILD exhibition. This patient, if they develop ILD de novo or for the first time, the radiological picture will remain the same in the form of diffuse ground glassing opacities and nodular opacities in the few cases. But besides the clinical suspicion, radiology might be just helpful in this in ruling out any other, because this patient are already immunosuppressed, to rule out any other infection reason. So we have to look at the radiology as something which is not atypical infection or any other reason for immunosuppressed patient which can be there. That's how we can. It's a more or less a clinical diagnosis, sir, in a proven case of dermatomyositis.
Yeah, but sometimes that when that is presenting along with the skin and joint features, then the extrapulmonary manifestations and the serology. Yes. This is what clinches the diagnosis, and the treatment has to be very aggressive because these patients go downhill very fast. So just starting one immunosuppressant may not be enough, and then there
usually with the cyclophosphamide and pulsesteroid, or may combine with
IVIG or
IVIG, MMF, or with the plasma exchange. Tacrolimus is also being shown.
Because some of the rapidly progressive ILDs we discussed, they have a good prognosis, but this one has a uniformly bad prognosis.
Bad prognosis, yes.
High mortality is there. So, Dr. Sharada, again, coming back to you. So, we have discussed organizing pneumonia. So what is the best tissue you think that will give a certain diagnosis of organizing pneumonia? And what are the histological features of organizing pneumonia? Dr. Sharada, your mic.
Yes, sir. Sorry about that.
So what do you look for? What kind of tissue should a pulmonologist provide to you, provided the patient is fit for that?
Sir, an adequate tissue biopsy, a cryobiopsy, I say will be should be around 5 millimeter square. That is what like most of the in the literature it is given. A 5 millimeter square biopsy, approximately 3 to 5 pieces is the adequate tissue for diagnosis of interstitial lung diseases. And coming to the histological features in organizing pneumonia, what we see is these fibroblastic plugs, which are seen in the alveolar spaces as well as in the bronchioles. So these fibroblastic plugs are nothing but the immature fibroblasts, which are mucopolysaccharide rich. So these fibroblastic plugs we see in the alveolar spaces and the bronchioles, and the other, the adjacent lung parenchyma is more or less it is like normal. So these are the histological features of organizing pneumonia. So apart from that, we can see the underlying etiology. Like for organizing pneumonia, there are a lot of other underlying etiological factors like infection, and then the drug-related changes also we can see, a connective tissue disease. So all these are causes of organizing pneumonia, which we can see sometimes in the biopsy, and we can say it in the biopsy that this is the feature or this is the cause of the organizing pneumonia pattern. But if we don't see anything and correlating with the clinical history, only then even a cryptogenic organizing pneumonia can be diagnosed. But a pathologist cannot give a diagnosis of cryptogenic organizing pneumonia based only on the biopsy.
We discussed acute eosinophilic pneumonia. So is BAL alone sufficient, or you would still say that give us a lung biopsy also? Acute eosinophilic pneumonia.
For acute eosinophilic pneumonia, most of the time it is diagnosed by BAL, but a biopsy can give an additional features, additional clues to the underlying etiology. Like if we do special stains, it can give a clue that, fungal etiology could be the underlying cause for this acute eosinophilic pneumonia. So biopsy will definitely help. Again, it should be correlated with the clinical history and also the BAL findings and also the peripheral eosinophilia feature findings in the CBC.
Thank you. So now let's just go back to the acute exacerbation of IPF and talk a little bit about drug management, because these patients have been managed on the basis of experience or few case reports or short series, but there's no definite evidence in favor of any particular therapy. So how we treat these patients, we give high doses of steroids, we give sometimes added cyclophosphamide to these patients. But more recently, evidence has come. There's a recent phase 3 study which has shown that a combination of high-dose steroid and high-dose cyclophosphamide in acute exacerbation of IPF, that has a higher mortality. And now people are moving away from pulse therapy of steroids and cyclophosphamide in acute exacerbation of IPF to lower doses of steroids. So that is a change, because like chronic IPF, it is not a very steroid responsive condition. Similarly, the acute exacerbation is also not a condition which responds very well to immunosuppressive therapy. However, the treatment of acute exacerbation of non-IPF ILD is still different, because compared to IPF, non-IPF ILDs have a substantial inflammatory component also along with fibrosis. So there the management differs. So that is one change which has come in last few years, that we don't manage all acute exacerbations similarly. So Dr. Nilanjan, how do we manage an acute exacerbation of a non-IPF ILD like RA ILD or a fibrotic NSIP going into acute exacerbation?
So, because strictly speaking, if it is idiopathic interstitial pneumonia, other than IPF, one is AIP, interstitial. It can be COP or can be the NSIP. If it is idiopathic. Now, certain associations of NSIP, if NSIP is strongly associated with connective tissue disorders, as Sir you have said, rheumatoid arthritis and RAIL. So, COP definitely responds very well to steroids, as Dr. Girish has 0.5 to 1 mg per kg dose of steroids, and can virtually the patient can almost
acute
be
exacerbation. Acute exacerbations.
okay. Yeah, so acute exacerbations also, steroids do have a role. If it is an acute interstitial pneumonia, there is not much role of steroids. But fortunately, in some cases, like the case I had presented, the patients did respond to steroids. Otherwise, there is not much of a response. Now, in case of connective tissue ILDs associated with connective tissues disorders, there again the initial treatment would be the first line treatment would be steroids. Strong immunogenic component. Then we might have to go for IVIG or plasma exchange. Hello? Yeah.
Now, quickly, because we are coming towards the end, so let's look at the critical care issues in these patients, because ultimately these patients who come with acute respiratory failure, management of respiratory failure, the supportive therapy is very important in these patients, because drug-wise, some of the conditions respond very well to steroids, some do not respond to steroids, but supportive treatment is required for all these patients. So, Dr. Arnab, in a typical acute exacerbation of IPF from an ABG, what would we expect? Mike?
Yes, sir. From ABG, definitely we'll get a type 1 respiratory failure. Definitely, that is the hypoxia and low CO2 level because of this high respiratory rate. But definitely, once the situation goes worse and the patient actually become fatigued due to this respiratory failure, then type 1 respiratory failure may convert into type 2 respiratory failure too. Yeah. But okay, so this is the ABG feature.
These patients have a very good respiratory drive, so they don't easily go into type 2 failure.
No, yes, sir.
So it's the prototype type 1 respiratory failure, hypoxic respiratory failure.
Yes, true.
Type 2 is there, then coexistent COPD or obesity.
Obesity hyperventilation syndrome, yes.
Right. So, Dr. Girish Agrawal, oxygen, that is the first treatment to be given to these patients along with antibiotics. So, what are the different ways in which we can give oxygen to these patients before we go on to devices? Only oxygen, different modalities of oxygen therapy.
Yeah, we can go with the nasal prong, with the nasal mask, or with the Venturi mask. We can also go with the NRBM mask ventilation. Or recent days, the role of HFNO has increased quite a lot in managing of acute type 1 respiratory failure.
We'll take later, just the oxygen therapy.
So these are the ways how we can give plain nasal mask, nasal cannula, nasal mask, Venturi mask, and NRBM.
Yeah, because these patients, we anticipate that they'll have a prolonged course. So we have to be prepared for the next step, because this is only the starting treatment. And very soon we have to decide that what is the next device that we are going to use. So, Dr. Arnab, what about NIV? Having started oxygen, patient requiring very high FiO2, 70%, 80%. Now, obviously, and the response is poor to just oxygen therapy without any aid. So, where does NIV fit in for these
definitely for in cases of this acute exacerbation ILDs, the first choice would be, if the normal oxygen therapy fails, the first choice would be high flow nasal cannula, because they can provide a fixed FI. We can regulate the FiO2 and we can give a very high flow up to 60 liter per minute. But definitely once the HFNC support is failing, or as you said, sir, if there is some coexistent condition like COPD or OHS and there is a type 2 respiratory failure, we can think of using the NIV.
So, Dr. Umesh, any experience with high flow nasal cannula? What are its advantages over NIV?
Yeah, I think as Dr. Arnab said, definitely I would go with HFNC as the first line. If the patient with conventional oxygen with nasal prongs or face mask fails. because as you have said, the patient is going to require oxygen therapy for a long period of time. So his comfort is very important. HFNC is definitely going to provide, is going to be more comfortable than having a bulky mask or open space. And also, we are going to achieve quite high flows, up to 60 liters of oxygen through our HFNC, and there is also going to be moist oxygen, so the patient is certainly going to be comfortable on HFNC rather than NIV. It's only when the patient starts going into type 2 respiratory failure that I would like to start him on NIV rather than HFNC.
Right. And the additional positive pressure that HFNC gives, that reduces the work of breathing and can improve ventilation. And the humidification is better with HFNC. So definitely, although we do use a lot of oxygen, and that is a concern, that it's a guzzler of oxygen, high flow is required. But some of these patients, now there's a dilemma that we face, and this question is for Dr. Arnab, whether to put the patient on mechanical ventilation or not.
Yes,
so
sir.
that is an issue which has to be answered, because in the absence of a treatable reversible cause, the mechanical ventilation is not really that kind of an option which we offer, for example, in patients with pneumonias or COPD. Right?
Yes, sir. Yes, sir.
So
Definitely.
is there any role for invasive mechanical ventilation? How would you select your patients in acute exacerbation of IPF or acute exacerbation of fibrotic ILDs?
Yes, sir. In cases of, definitely, if the patient is due to acute exacerbation of IPF, there is already an ongoing inflammation is going in the lung, and there is a, if we put these patients on ventilator, there will be more ventilator induced lung injury would be there. And so for these patients, if the patient is planning for a transplant, that is a separate thing, or the exacerbation is due to some reversible cause, like, some infection or kind of pulmonary embolism or kind of thing, definitely then we can think of this. But otherwise, in cases of IPF, we don't think this would be a mechanical ventilation would be a
That
very
is
good
very
option.
important to counsel the family that if there is no reversible cause, so that is why, as we discussed earlier, the reversible causes like pulmonary embolism, heart failure, infection, these must be identified because they offer hope to the patient. If reversible causes are not there and just an acute exacerbation and no other cause is found, then one would think twice before putting these patients. So supportive therapy with HFNC to provide some level of comfort, that is the option. And therefore, selection of patients for mechanical ventilation is very, very important. And as you say, if you're planning more aggressive therapy, then it becomes a bridge towards further treatment. So, Dr. Nilanjan, in case we decide to put the patient on mechanical ventilation, we are planning to escalate to more aggressive therapy, then what is the ventilatory strategy in brief for these patients?
Yeah, so when ventilating a patient of ILD is going to be extremely challenging because the patient's lungs are going to have a very low compliance. So these patients are going to have a very high airway pressure. The plateau pressure is going to be very high even if we use a low tidal volume. So the strategy is definitely going to be lung protective ventilation using low tidal volumes. PEEP is not going to have much of a role as the alveoli are more of a fibrotic lung. So yeah, lung protective ventilation, keeping the plateau pressure less than 30, so as to prevent complications.
Typical ARDS strategy.
Pneumomediation, yeah. Except probably the PEEP, I would not increase much because it's not going to help.
And you would favor an early tracheostomy in these patients?
Yeah. It depends on what the destination is. Like if the patient is going to for a lung transplant or something like that, then we might have to put the patient on something else like it. Otherwise, if we are able to wean the patient off to some degree, we'll have do an early tracheostomy and try to gradually from the ventilator.
So, Dr. Girish, ECMO, is there any role we can think for ECMO?
Sir, basically, there are two roles of ECMO. One, those who are on the mechanical ventilation bridging for transplantation. So there we can apply ECMO if there is supposed to get the lung transplant in the near future. And then second is to avoid mechanical ventilation. So those patients who are failing on NIV, what ECMO basically does, it reduces the trigger and the persistent damage which may occur with all the ventilator mechanics.
That is a very important issue, ventilator-induced lung injury.
Yeah. So ECMO preventing the invasive mechanical ventilation is a point where ECMO can be considered. And for those who have already been ventilated or even those who have not been ventilated, ECMO can be used as a bridge.
Right. So, Dr. Umesh, finally to you, lung transplant, any personal experience?
No, I do not have a personal experience with lung transplant, but we have indeed sent a patient on ECMO to another center for lung transplantation. And this was a similar case of patient who was a young girl of 17 years. So the relatives wanted to do everything possible. So we had to put her on mechanical ventilation, bridge it with ECMO, and we have sent the patient on to a transplant center where she eventually, after 3 weeks of ECMO, she had got a donor and then bilateral lung transplant. So I think if the destination is where a lung transplant is the only option if you are having extensive ILD.
Thank you. So I think we have considered, discussed most of the aspects. Let me see if there are any questions from our audience. The role of HFNC we have already discussed. Dyspnea and diaphragmatic palsy, that is outside the scope. Pulmorenal syndrome. I think questions are more related to respiratory failure than acute. Role of steroids in non-IPF ILD that has been taken care of. How many alveoli should be seen to call it a good TBLB or a TCLB? Quickly, Dr. Sharada, do we have an answer to this? How many alveoli should be seen to call it a good TBLB or a good TCLB?
So the number of alveoli has not been mentioned in the literature. What the literature says is the biopsy should be at least 5 millimeters square in diameter.
Gross size that.
Yes, sir.
Right.
And it should be taken from 2 different lobes. This is what the literature says.
And Ball cell count in acute ILD exacerbation, I don't think it has any role except that
Neutrophil counts.
But microbiological workup, definitely Ball would come in. I think I think the discussion went off very smoothly and we discussed all the issues, acute exacerbation of IPF, acute exacerbation of non-IPF ILDs, ILDs with rapid presentations, complications which can cause respiratory failure but are reversible. So I think we have had a fruitful discussion and it's my pleasure to thank the participants. So Dr. Sharada, your inputs were very valuable as a pathologist. Now, this is an acute condition, so we are always limited in providing tissue to pathologists and a patient who presents with a respiratory failure. But definitely, your role as a person who helps in reaching a final diagnosis is valuable, cytology or histopathology, and it must be taken advantage of. I would like to thank Dr. Arnab Bera for his excellent inputs, Dr. Girish Agrawal for excellent discussion. Dr. Nilanjan Umesh's case was very illuminating and set the tone for the discussion. And Dr. Nikhil Gupta covered a wide range of the radiological abnormalities in these patients. So overall, I think we all stand to gain. We are wiser after the discussion, and I'm sure the message has gone across that it is a condition to be recognized. It is a condition where our limitation of treatment have to be recognized, and we must try to identify the reversible factors which can be treated. Infection workup, exhaustive is required, and then critical care aspects, how to use HFNC, which patient to ventilate, which patient not to ventilate, and finally escalating to lung transplantation. So I would like to thank all the participants, my excellent panel, for this illuminating webinar, and also thank CCI founding chairman Dr. Krishna, president, then Dr. Vijay Chanamchatty for excellent introduction to the topic and of the speakers. So Dr. Vijay is still around or has left? So he's not there. So my vote of thanks to all of you. Thank you very much for all your inputs.
Thank you so much.
Thank you, sir. Thank you so much, sir, for your moderation as well.
Excellent moderation, sir.
Thank you, sir.